Thanks to everyone for joining today's presentation. Virginia referenced the chat function for questions. Technical questions will be addressed as they come in, and content questions will be addressed at the end of the presentation. If you would like to download the slides from this presentation, please use the icon on the top right of the screen. Additionally, live closed captioning is available at the bottom of the screen. Slide 3, please. My name is Chris Duff, and I'm a disability practice and policy consultant who has been working with the Lewin Group to develop disability competent care, the disability competent care model, and related webinars and materials. I will be joined today by another of the co-authors of the Disability Competent Care Model, June Kale. June consults on the integration of inclusive service delivery processes, procedures, protocols for many health plans and medical centers. June is also the Associate Director of the Harris Family Center for Disability and Health Policy at Western University of Health Sciences, Pomona, California. Most of June's work has focused on building critical, actionable disability practice competencies in healthcare and emergency management in order to deliver equally effective services to people with disabilities and others with access and functional needs. Slide 4, please. On behalf of the Lewin Group, I would like to welcome you to our Disability Competent Care webinar series. The Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services has contracted with Lewin to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees. This series will consist of 7 webinars running on Wednesdays at this time through March 22nd. All the webinars are being recorded and will be available along with a PDF of the slides at the Resources for Integrated Care website. In 2013, we published a comprehensive disability competent care self-assessment tool describing disability competent care, and has since produced 25 webinars on the topic, along with numerous supporting tools and documents. These are also available on the RIC website. The DCC material has recently been revised to be more accountable to users and reflect further development of the field. It is now structured in 7 pillars of disability competency. In this series, we are introducing the 7 pillars with a webinar dedicated to each, and we'll be allowing at least 15 minutes at the end of each webinar presentation for discussion and questions. As you can see in the slide, today's is the 3rd pillar. Please excuse, I believe we're having some trouble getting the slides to move along, but they will be available to you on download. We would like to solicit your opinion on this service, as well as past webinars and supplemental resources. Please take the time to complete our survey at the end of this webinar and send us your ideas for future topics and content. Contact information is listed at the end of this presentation. Today, we will focus on access from multiple perspectives. The disability competent care model focuses on not a disability per se, but on the functional limitations that occur as a result of a disability. With the goal of maintaining or achieving health and obtaining healthcare services, it is necessary to address access to as a barrier to care. The DCC model, Access, describes access barriers in 5 groups: internalized attitudes and biases, accommodations, physical accessibility, communication access, and programmatic access. Some of them are fairly concrete, such as physical and communication accessibility. Some require personal reflection, such as attitudes and biases. And others require an understanding of the health and social service delivery systems in your community, such as programmatic access. As I stated last week, access, in the broadest sense, is perhaps the greatest problems faced by persons with disabilities as they attempt to achieve health and obtain health care services. Research has repeatedly shown that persons living with disabilities experience a range of health disparities, and most all of them are related to issues of access. The result is inadequate care and poor outcomes. For example, persons with disabilities commonly experience difficulty or delays in receiving necessary care, and they fall short on targets in rates of important screening tests. Due to difficulty obtaining primary care services and reliance on specialists, their preventive care is often neglected. Many have not had dental care and don't routinely receive relevant sexual health information. Even something as basic as hypertension is not identified and addressed at the same rates as the broader population. There is also a variety of social factors impacting health status and outcomes. Many people with disabilities rely on Medicaid and or Medicare for their health care services. For example, Medicaid is income tested, meaning the recipients are living on a very limited income and thus financially challenged. These programs are going through extensive research, moving from fee-for-service to value-based purchasing. As the payers are beginning to focus on outcome measures, such as cancer screening, vaccinations, and diabetes management, the clinical interventions are straightforward, but communications and service delivery stretch the disability competence of most providers. Of course, many of these are directly related to the access issues June will discuss shortly. Add to that the financial, eligibility, transportation, and other challenges, it is no wonder they experience poorer outcomes. For many providers and plans, improving outcomes for people with disabilities will have a direct impact on revenue. At this point, I will hand the presentation over to June.
Thank you, Chris. And I'm sitting here in Southern California, and the sun actually came out. So it's typically been raining here nonstop, so it's nice to see the sun. So first, I want to give you the visual, since you won't have it. I dressed up on your behalf today. No Friday casual, and I'm not sitting here wearing my sweats. So before I cover slide 10, I want to really sum up the content of the webinar today by saying I'm going to talk about attitude, about asking and attending to physical, equipment, programmatic, and communication access. So I kind of abbreviate that, and I say it's 3 A's to PEPC. PEPC standing for that physical, equipment, programmatic, and communication access. So I'll cover 3 competencies: being aware of and controlling your disability-related biases, that's attitudes. Second is asking, listening, learning, and respecting and using information from participants. And thirdly, attending to or attention to detail. So building and baking these AAA competencies into your culture and your systems takes strong and sustained attention to applied practices, programs, procedures, protocols, trainings, and audits. The goal really is hardwiring these actionable practice competencies to reduce those disparities that Chris talked about. And that is a higher incidence in people with disabilities of obesity, of smoking, of physical inactivity. People with disabilities are 3 times more likely to have heart disease, stroke, diabetes, and cancer than adults without disabilities. And nearly half of all adults with disabilities get no aerobic activity. And so these adults who don't get this aerobic activity are actually 50% more likely to have these chronic conditions. So baking in these competencies reduces other costly barriers as well. Barriers like appointment failures and substandard and unequal treatment, as well as adverse events. And, more positively stated, making these competencies actionable achieves equitable and effective care and includes offering any of the needed services and accommodations. And that all results in improved health. Folks, tell me, you say, hey, June, this content is just common sense. And I say, yes, it is. But the gap between common sense and implementation, moving that needle, is wide and deep. I know it can be hard to not see us speakers, and so I'm going to try and keep you busy so you don't get sucked in by that unanswered email. So I'm going to try my best to keep you active. So I ask you, one, in terms of staying active, to keep a running list of your next actions based on what you hear and how it relates to what works, what doesn't work, and what needs work in your area of practice. So take a moment to list some of the compliance drivers behind PEP-C, program equipment, physical, and communication access. Just take a list. Take a moment to make your list. So I've got 6 items on my list. How many did you get? First is the Americans with Disabilities Act. Despite over a quarter of a century since its passage, and also over a half century since the passage of a second driver, the Section 504 of the Rehab Act of 1973, compliance is far from achieved. Additional compliance drivers include 3 state and federal contracts, 4 CMS regulations, 5 performance and quality measures, and 6 the increasing legal activity focused on PEP-C. So in my view, and we focus on this with the disability competent care tools, I don't use disability etiquette or sensitivity or awareness because I think they're kind of soft and weak as compared to the weight and value when we talk about actionable disability practice competencies. So slide 10, attitudes. Attitudes are the most silent but impactful barrier in terms of the first competency. just take a moment to think about your experience with customer service with an attitude. List the words that describe that experience. Make your list. So when I ask people to do this, people give me words like maddening, frustrating, condescending, paternalizing, dismissive, paternalistic, defeat, being exhausted by a non-responsive system. That's what it's like for some people with disabilities who encounter attitudinal barriers in healthcare. It might be more nuanced, and it might be more subtle. So I'm on slide 11. This attitude competency involves engaging in your own self-reflection regarding your beliefs, prejudices, stereotypes, and fears. Where do they come from? Are there messages you get from your culture or messages you got growing up about disability? How do you contain the negative ones so they don't leak out and interfere with your providing effective care? So we're on slide 12, and these are all examples from real people's stories. I did not make any of them up. The attitudes are, if you can't stand, you can't walk, you can't stay still or hear, then we can't do this, or we can just skip the test or the exercise or nutrition class. And we assume you're not a sexual person, so we could skip the birth control, the HIV, and the STD discussions. So we get attitudes like, of course you smoke, you eat too much, you drink, you're depressed. If I were you, I'd do that too. And one of my favorites, this is an ambulatory clinic, and you can't walk, so we really can't help you here. It's very common to equate disability with a lesser quality of life. So I'm now in 12th slide. I need to remind you that if you're on the phone, you need to turn on your computer to hear the video we're going to play. But if you're not able to do that, you can catch it on the RIC website, because all of these webinars will be archived. Go ahead with the video.
I have several proposals I've had all my life. I am a writer, disability educator, and I'm married and have an adult son who's 25.
Okay. Well, Denise tells another really interesting story. She saw a specialist, and the specialist gave her a letter to carry back to her primary care provider. It was a consult with a specialist. And like most curious people, she opened and read the letter before giving it to her PCP. And it read like this. We saw this unfortunate 57-year-old woman in our office. My impression is she is far more intelligent than she looks to be. So you can hear a lot more of Denise's interview if you go the Healthcare Stories Denise. Healthcare Stories Denise. There are a lot of great stories on that website done by Dredif, D-R-E-D-F, and they're excellent glimpses into her experience and the real-life experience of others with disabilities. You know, Fred also says that because of his speech disability, they always assume they won't understand me, so they don't even try. And some people don't think I'm intelligent enough to communicate with just because of the way I talk. Attitude. It's all about attitude. Gail went to her doctor and explained that she needed birth control, and the doctor said to her, "Why would you need birth control? You're blind." So, all right, just to keep you busy here, I want you to create a list, 2 columns. I want you to, in the first column, write the words that describe the message, and in the second column, write down other words that describe the second message. So here's some messages. 1, you'll never be able to walk again. Versus the second message, you'll have to explore some alternatives that will allow you to continue to work. Another message. 1, you will always be an invalid. Versus 2, you will have to explore new ways to use your strengths and skills to meet your goals. And the last one. 1, talking to a parent, spouse, or partner or child, you will have to take care of them. Versus 2, together you can explore new ways to maximize their independence. So the first step communicates no hope, it's over, you're washed up, there are no options, and you're unable. Unable is pervasive. The second set communicates hope, encouragement, and options, and doesn't assume a lesser quality of life because of a disability. So as slide 9 read, stereotypes are based on assumptions that run deep in our culture, so deep that they could slip by unnoticed unless our awareness is continually sharpened and refined. So slide 13. So I think it's important to self-reflect or to ATC, acknowledge, tag, and contain any biases that are negative. These biases, they just don't go away. Stereotypes, frankly, are inevitable. And for me, it's about white men with Southern accents. Don't ask me where that came from, but that's one of my strongest stereotypes that I have to keep in check, tag, and contain. So we all need to go through this analyzing of our biases so that these negative ones don't leak out and don't cause us to assume things like health, wellness, and disability cannot coexist, or physical illness, decline, and other conditions don't have to accompany living with a disability. Another expression of underlying bias, our attitudes, our images chosen from media and marketing content. Take a moment to think about the pictures, the images that promote your services, your plan, your clinic, and your hospital. I frequently see images of isolated, depressed people with disabilities being cared for or being poorly portrayed by actors or models. You know, in the disability subculture, we use code words, and we call these folks fake gimps, and we can easily spot them. So stronger images without biases are real people with disabilities who are active and engaged socially with others, picnics, partying with friends, singing in the choir, parenting, are participating in like an inclusive exercise class where some sit, some stand, and some use interpreters. Slide 14 is the second competency, which includes asking, honoring and respecting the lived disability experience, the details, the diversity, and the nuances of living with a disability, which can't be duplicated or thoroughly understood unless one integrates the practice of asking, listening, learning, respecting, and incorporating the information learned from people. It's a critical healthcare competency, and its use of insider information that you won't get arrested for. Insider information is vital. It's a vital source of knowledge for understanding accommodations needed, and it gives depth to the meaning of an important disability tenet, which is you've seen one person with a disability, then you've just seen one. It's understanding that disability is not about doing an exercise that artificially tries to simulate a disability in a time-limited experience like wearing a blindfold or using earplugs or using a wheelchair. So the asking competency means effective listening, asking, and always asking what works for you, making no assumptions, always saying, can I assist you, and waiting to get the answer, and if it's yes, following up by asking, how can I assist you? Many of us have sophisticated knowledge about our bodies and the most successful approaches and options for our healthcare management. My favorite story is I went from mammogram to a place I've been going to for years, and there was a new technician. So I said to her, you know, we need 2 technicians to get good pictures on me. And the tech said, oh, honey, I've been doing this for years. Let's do it my way. And I said to her, oh, honey, I've been doing it for years too. Let's do it my way. So after a brief pause, she did listen. And I know that that's a real sophisticated response on my part that probably took years for me to have the guts to say. But in the end, the technician said, you know, you were right, and I'm glad you really spoke up and you kept what you said. So some very good real stories are also covered in a webinar we did in 2015 on May 13th called The Lived Experience of Disability. So slide 15 is the third competency, attending to the details of the accommodation needs. Slide 16, I'll cover a little bit later. Slide 17, once the need is established, it should be recorded, referred to, and updated. But, as slide 18 illustrates, how do we know what someone needs? We don't know. It's critical to ask everyone. And a routine question that I use and promote is, will you need any assistance with getting on and off the table or other equipment, walking, seeing, reading, hearing, filling out forms, communicating, speaking during your appointment? Or will you need an interpreter? Or I just want to make sure that all this information is still correct. This is information that needs to be recorded in a consistent place and referred to before and during appointments and updated. And the details have to be probed if someone says yes, either by the receptionist or by a call back from a staff member. One resource for you is questions to ask for identifying communication and accommodation needs. Those illustrate some of the probes underneath the questions, and we'll put that in the chat box, that resource. Slide 19 is about physical access. Probably the best understood, but not necessarily communicated or available, and not always known to member services, care managers, case coordinators, the social workers, or others, so they can have accurate information about providers' accessibility when asked. Slide 20, physical access got to be a part of evaluating network adequacy so members are not confronted with insurmountable barriers leading to appointment failures. That means path of travel barriers that are barely perceptible to people might as well be the Great Wall of China for people with mobility disabilities. Buckling sidewalks, just one missing or unsafe curb ramp, lack of accessible parking spaces, waiting areas, bathrooms, or exam rooms that are too small to accommodate mobility devices or to navigate in. Slide 21. A call to an office clerk who may not understand the meaning of the details of a vague question, is your office wheelchair accessible, contributes to the risk of an appointment failure. Better practice is the use of consistent and accurate information derived from trained surveyors using a detailed, well-constructed survey tested. And one example is that one we use in California, and that's available from DHCS PARS. That would be Delta Hotel Charlie Sally, and PARS would be Papa Alpha Romeo Sally, and we'll put that in the chat box. So slide 22. Is about, that's probably better labeled as slide, accessible medical equipment, which is also a form of physical accessibility. Height adjustable tables and chairs make an independent transfer possible for many, as well as an assisted transfer or a dependent transfer, safer for participants and staff. Accessible wheelchairs located with other vital equipment is important for getting accurate weights. It's a critical part of the standard of care for many visits, and being told to guess your weight is unequal or inadequate care, or being told that we'll just examine you in your wheelchair is also inadequate care. So slide 22 is about, moving on, I'm sorry, to slide 23 is about communication access. And that's about getting, understanding, and using information and providing aids and services. Slide 24, communication access is probably one of the least understood and where some of the greatest mistakes are made. Communication access means providing content in methods that are understandable and usable by people with reduced or no ability to speak or see or hear, or limitations in learning or understanding. This includes people with cognitive and intellectual disabilities, and includes people with limited language proficiency. So communication access takes many forms. Different formats: audio, digital, large print, pictures, models, braille, interpreters, readers, writers, assisted listing systems, computer-assisted real-time captioning or CART, captions, accessible websites, and good procurement contracts that make sure material is always available in those formats. Slide 25. There are many in this group. It's really an unrecognized large group of the population that benefits when content is offered in formats other than standard print. And you know what? Almost everybody benefits from pictures and models. And audio format helps many people with moving and seeing and learning and reading and language limitations. Slide 26 is about program access to services, and is needed by some to be able to benefit from the physical communication and equipment access. So, for example, although transfer onto and off of a height adjustable medical equipment is safer for all, some still need transfer assistance. But lift teams or lift equipment or lift training doesn't yet exist in many places. Hence, we hear much too often, again, we'll just examine you in your chair, which means, again, unequal treatment. A woman explained in a focus group I led, I've delayed visits to doctor's offices because it takes a village to get me on and off the exam table, which means I just don't go for preventive care appointments. Other types of programmatic access assistance include longer appointments to accommodate people who need more time to speak, to ask questions, and to understanding answers, or to use interpreters, or to use CART. Program access can include sending forms out ahead of time, or reading them at the appointment and filling out forms at the appointment, as well as transportation assistance. Slide 28. The goal with PEPC is to integrate these needs into practice, so when making referrals for health care or to community providers, the needs are met and the referrals are not failed attempts, but successes. And reflecting back to the question, will you need any assistance with getting on or off the equipment, walking, seeing, reading, hearing, or filling out forms or communicating? To repeat, these needs, these answers have to be highlighted in the record in a consistent and prominent place where they can't be missed and are not buried in the electronic health record or missed because the user has alert fatigue. I know in the ethics system, the header, it comes up in a yellow header first thing, so it won't be missed. So I call these quality service accommodation alerts. Again, they're referred to before and during appointments and routinely updated. Slide 29 is our, I call this our Star Wars graphic. In our work with many health plans, we find that the integration of the accommodation needs across services is a huge problem, primarily because data systems are built on a variety of incompatible platforms. And this is a big need, needing attention. For example, even though all the Medicaid plans in California have good data regarding physical accessibility of primary care, specialists, and ancillary healthcare providers, the staff, care coordinators, case managers, and others cannot access the information always, or it's not provided in the provider directory or on the plan's website. So staff, in an attempt to do something, will revert back to the inadequate practice of calling and getting inaccurate or uninformed answers, as we've already discussed. Another aspect of this that needs attention is that current requirements remain silent regarding the integration of accessibility into network adequacy. This is a critical bridge to healthcare equity for a large slice of the population. For example, there may be 15 gynecologists in a provider network who are within the allowable time and distance requirements of a member who is a wheelchair user. But if few or none of these gynecologists have physical access to and through the facility, height-adjustable exam tables, lists, or available trained personnel to assist with transfers, then none of the providers can provide the member with effective care. Should this not be a key element of network adequacy? So slide 13, we have Annie, and the objective of achieving successful referrals and system navigation includes the integration of this accessibility, which means all players and staff need access to accurate information to help Annie with her community, taking advantage of community services as well as healthcare services. So making it happen, slide 31, I'm not known for my patients, and I want change to occur in nanoseconds and not in geologic or glacial time, but I reluctantly learned that I and you just have to be raging incrementalists to be real change agents. So slide 32, slide 32, I refer you back to your next action list. What's on your list? First, I remind you that this is multiple exposure material. To hardwire this into your culture and your systems takes that sustained and continued attention to those AAAs and Pepsi. The results, you won't have to scramble at the last minute to meet known and hopefully documented needs, and you'll be able to offer access elements smoothly and without unnecessary disruptions, wait times, or delays. It's just part of that right stuff at the right time using the right delivery methods. So slide 33, I'll take the opportunity to list 10 items for you, for your next action list that you may already have on your list or want to add. Okay, you got to take these down because they're not on the slides. So one, be an incremental improvement maker. Use this content to look at what works, doesn't work, and needs work in your area of practice. Two, you could assemble small work groups or learning groups to do a deeper dive. Three, you could weave and insert this content into places where these topics are or need to be discussed. Four, you can integrate this content into your quality improvement discussions. Five, you can use your advisory groups to probe and discuss what needs work. Six, you can use the DCAT tool you've heard about in this website series. Seven, you can get feedback in integrating questions regarding Pepsi into your member satisfaction surveys. And 8, you can use another tool that we'll post or you can Google called the Competency Planning Checklist, for providing health care for people with disabilities. Competency planning checklist for providing health care for people with disabilities. That'll be in chat. 9, you can bring in trainers and consultants to help. And finally, 10, you've got the opportunity now to ask us those challenging questions. So back to you, Chris.
Thank you, Thank you, June. A wonderful and very detailed presentation. I really appreciate it. We're going to go to some questions, but before I do that, I wanted to just clarify. Some people were asking about access to the previous webinars, and the PowerPoint slides are available immediately. In fact, the PowerPoint slides for this presentation are available right now on the RIC website, Resources for Integrated Care. But if you want to listen to it, that will take a week or two to get up on their website because they need to go through some processes and so on. So the slides are available immediately, and listening will take a couple more weeks. So with that said, I have several questions that come forward. The first is, what is required of me, a health plan? This person says they're working a health plan. In terms of the access, I think this question came up last week too. In terms of the access of our provider network, I think it's unrealistic for all of our providers to be fully accessible. Julie?
Well, it is unrealistic, but what is realistic is offering accurate information about which providers are accessible and factoring in network adequacy to make sure that there are enough of different types of providers that can offer access. And the other model is that some plans have addressed barriers when there hasn't been network adequacy and have offered providers assistance with barrier removals or acquiring accessible medical equipment. There's some nice new models out there that are doing that. Back to you, Chris.
The California survey of primary care settings that was linked in probably at about probably about almost 30 minutes ago, is a great tool that with a lot of diagrams, a lot of data on it, that all health plans are expected to administer in all their primary care clinics. I believe it's every other year. The great thing about that is they put it into their database so their member services and care management staff can have access to it and will know which provider has what level of accessibility in terms of whatever the issue may be. That's what we encourage plans to do is you're right, you can't expect everyone to be 100% accessible. And in fact, I think you can't expect that no one will be 100% accessible. But the important thing is knowing who is in what detail and making sure that the member gets that information.
So when we look at provider directories, Chris, in California, we've got the opportunity to know whether that is a provider I can use or not. And we've got accessibility indicators listed in terms of parking, restroom, internal and external pathways, equipment and scales, that kind of thing.
That's great. And of course, California is way ahead of us. We've been doing this for, I think, 15 years. But you got to start somewhere, and this would be one place to start. Another question is, when I refer a member to a provider, is it my responsibility to communicate their accommodation needs, or is it the provider's or member's responsibility to identify? I don't want to be disrespectful of a member by doing it without their express permission or request. I think she's concerned, or he's concerned, about being condescending and patronizing by doing so, by speaking for the participant or member.
So, Chris, I think the answer is yes and yes. I think that it is never a mistake to repeat and we enforce and emphasize the importance of accessibility, both by the staff member making the referral, as well as to let the member or participant know how important it is that they develop their own survival advocacy skills in asking for any needed accommodation, and that they not be complacent about thinking, well, I told them when I called. But actually, we found that what really works is to tell them when you call, remind them the day of your visit, and remind them when you get there. So this is a survival skill set for people with disabilities, and it's a great coaching mechanism for staff to use with members in terms of teaching those survival skills.
Great, and I wanted to thank Jennifer Valentine for putting in the chat function some work they're doing in Oregon, which I think is great. And if anyone would like to connect with Jennifer directly to find out about how they're communicating with their plans, what their written expectations are, put that in an email to one of the people on our last slide, and we'll make sure that we can find her and get it forwarded to her. I appreciate you doing that, Jennifer. Another question is, can you offer ways to easily convert information to audio?
Okay, you mean audio format. Yeah. You know, sometimes you need information converted really quickly, like you've got to recommend that somebody get an emergency procedure, say a colonoscopy. Now, those are pretty complex kinds of instructions, and if you need them in audio and you need them like quickly, what do? So there's some really easy things that we forget about, like if somebody has a smartphone, you can read it into the recording device on their phone. Or you can read these complex instructions into their voicemail. You may have to do it in part 1, part 2, and part 3, but it's doable. And these are good techniques for people. You can't assume that people live with somebody who can always read things to them. Sometimes they do, but sometimes they don't. So those are real quick ones. And you can't also, Chris, I think it's important to not forget medication labels, which is a huge area of, adverse events for people because they're not able to read the labels. So there's great new technology out there that translates the contents of medication labels into audio. And you can affix labels to any kind of shape of container. And there's good technology out there. One source is you can Google Script Talk, S-C-R-I-P talk. So good technology out there for audio. And then I'm also working on a fact sheet related to other tips that might take a little more time.
Great. Thank you. Thank you very much. I wanted to get to a question that came in over chat. And I don't know if June or I will have an answer, but I'll give it to June and we'll see. Are there any HIPAA concerns when leaving detailed instructions on a voicemail? Like, let's say the plan is calling about a member and they're leaving detailed information about their member's needs for their upcoming visit.
Well, I'll take a stab at that. I think you're doing it, with the member's permission, and sometimes you're doing it with the member right there so they can actually listen to what you're inputting onto their voicemail. But it is with a participant's permission. So you're not giving really diagnostic information. You're giving instructions as to how to prepare for a procedure. Okay, Chris, your turn.
Yeah. The other thing I would say is I agree with what June's saying, but when in doubt, whether you're a provider or whether you are a plan, working within a plan, I would encourage you to go to either your compliance office or however you guys are organized and ask that question. about internal practice. You're right to be always concerned about privacy, but I think there's a way to do this. We're nearing the end. In fact, we have about 2 minutes left, but I will give June one more question. Can you give us some examples of the probes you mentioned when asking, will you need any assistance with getting on and off table, walking, reading, seeing, and so on during your appointment?
So let's say someone says, yeah, I need to know walking. And so the probe would be, okay, will you be coming, do you use a wheelchair, do you use a scooter, what do you use? And then will you need assistance being able to move from your scooter to the x-ray machine or the exam table or the diagnostic chair? And then, okay, will you need a hand, or do you need lift equipment? Tell us specifically what you might need so that we're ready for you. And can you step up onto a scale, or so you're probing those kind of details.
Well, all I would add to that is the California Primary Care Site Survey and the work that's being done in Oregon will give you some of the details that might help you figure out, okay, so getting up on a table is more to just having the exam room be accessible. It's can a person get in the exam room? If they need transferring assistance, is there equipment to transfer? Are there staff to transfer? So by just becoming familiar with those assessment tools, that will help you understand the kind of drilling down that you will need to do. So even though we've had another questions come in or two, I think I need to wrap it up and thank everyone for your questions. The last question that came in, we'll try to send it. I'll send it to June to see if she can follow up on it directly with you. We're going to wrap up the presentation now. Please send any feedback you have to the RIC email address on this slide. Additionally, please take the time to answer the survey that will appear on your screen at the end of the webcast and will also be emailed to you very shortly. Again, I'd like to call your attention to the resources that we have online at the Resources for Integrated Care website, including the Disability Competent Care Self-Assessment Tool. Please join us 1 week from today for our 4th webinar, Disability Competent Primary Care. The presenter will be Dr. Judy Chamberlain, who is Medicaid Medical Director for Aetna. Again, I would like to thank you and for attending, and the Center for Medicaid and Medicare Coordination for sponsoring this webinar and the entirety of the Disability Competent Care work. Thank you.